the challenges we've faced over the past week, and also how we're dealing with those challenges as best we can. Why are we coming from UCD and from the O'Brien Centre for Sciences? For a number of reasons. It's a great location, but also it is the home of the NVRL, and I'm sure all of you will have heard of the NVRL a lot over the last number of weeks. And also, secondly, it is a centre for contact tracing, one of the many centres for contact tracing that we have around the country. So I'm going to ask the panel to introduce themselves, starting with you, David, with your name and your appointment title, please.
I'm David Walsh. I'm the National Director for Community Operations.
Chief Clinical Officer, HSE.
Siobhan Kennelly, Consultant Geriatrician and Clinical Lead for Older People, HSE.
Paul Reid, CEO at HSE.
And I'm Paul Connors, National Director for Communications with the HSE. We're also joined by Lisa and Margaret, who are our Irish Sign Language interpreters. And also, I'd mentioned the NVRL. Dr. Cillian de Gascoigne, the Director of the NVRL, is also here with us today. So the format, we have two speakers. Firstly, Paul will give a general overview, and with a specific focus on testing, on PPE, and also on nursing homes. And then Colm will give a clinical overview, and he's going to discuss in detail 3 new testing categories, and that should be of interest to everybody. We're streaming this, obviously, live through RT now, and we're also streaming this through HSE Live. And as I say, at all of these briefings, if you're following this streaming through HSE Live, if you can use earphones, headphones, please do that, because the sound can be somewhat difficult, but it works very well with headphones. So we'll get on with the start of the 2 speakers. So can I ask Paul to come up? Thank you.
Thank you. Good morning, and thank you, Paul. Good morning, everybody. As Paul mentioned, I want to briefly update on 3 key areas that have been hot priorities for us this week, which are testing and tracing, PPE in terms of supply and demand, and nursing homes and the supports for long-term residential centres overall. I will actually just briefly set out some details on recent recruitment and numbers through the Ireland On Call and general recruitment overall. Firstly, to update you on our overall testing and tracing capacity and where we are at right now. We've now eliminated any backlog for lab testing, and we've significantly built up our capacity, and now at a position where we're meeting the existing demands set out under the current definitions. So we have a 0 backlog, which I committed last week we would have by the end of this week. We've increased our lab testing capacity, and ENFR are now operational and fully on board, supporting us in the testing process. We're just finalising a commercial agreement with the German laboratories, who have been very supportive as we have tackled the backlog in particular, played a very significant role in eliminating the backlog. And we will finalise the commercial agreement with that laboratory. So I have on the slide here, we now have a total of 27 laboratories on board working for us as part of this overall Covid-19 response. 26 of them obviously in Ireland, ranging from our acute hospitals to some community settings, and then, as I mentioned, through our own NVRL and ENFR and others. Across the 27 laboratories, we've proven capacity last week of doing just about 1,000 laboratory tests in one day. And again, 26 of those 27 labs, in essence, carrying out about 60% of the total volume of completed tests, and the remaining being done through Germany. I mentioned earlier on a previous briefing some of the challenges we had in terms of supply of reagents. Again, we've made good progress over the last week on supply of reagents. 150,000 reagents from a supply line we secured through China has now gone through a completed QA quality assurance process, and they are finally being distributed across primarily through the hospital system. We've also made good progress in relation to supply lines from Irish-based global organisations, I'm happy to say. We've now over 11,500 number of swab tests completed in the community last week. We currently have a capacity to do about 7,000 roughly in our 48 testing centres, and the remaining are being supported through our National Ambulance Service, which I'll come back to in a moment. However, in terms of overall testing and tracing, our primary focus and priority focus now remains around three key priorities, and I will ask Dr. Colm Henry, our Chief Clinical Officer, to go through those priorities, but just to say from my perspective, they are the priorities driven by our long-term residential care settings, nursing homes, private and public, for our residents and patients in those locations. But Colm will bring you through the prioritisation, and that is what determines the priority of our testing over the coming couple of weeks. We're finalising an operational plan to deliver on all of that, and that testing, which is very significant. But I will just say, already over this weekend, between Saturday and today, we will have completed 4,000 tests in both residents and staff in those long-term care settings. A very significant ramp-up, and I want to thank our National Ambulance Service for their work throughout the weekend, continuing today. 2,000 alone completed yesterday. It is important just to say, as we are focusing on the priorities, that 60% of nursing homes don't currently have COVID-related cases. However, we do want to be very proactive and support these homes in the testing process. And again, Dr. Colm Henry will bring you through that in a little bit more detail. Second area I wanted to brief you on related to our PPE supply, which you know has been a significant challenge, global challenge, worldwide challenge in terms of supply lines. I wanted to update you where we are in particular right now. It continues to remain challenging, and we are now aiming to accelerate further deliveries that would have been planned much further out into May and June into now consolidated into an accelerated larger order, and I'll bring you through that just very shortly. But firstly, the batch 1 order that I will have spoken to you about, which was a value of €31 million and 33 million items of PPE supply, has been fully delivered to us and distributed all across our hospital and social care areas. Any product issues that were there in terms of the batch 1 orders have now been fully addressed as part of our batch 2 delivery. And that batch 2 now commences on the 18th of April, has commenced since the 18th of April. A number of flights over the coming weeks. The batch 2 originally to an order of €67 million. However, what we have done as part of that, as I mentioned, to accelerate further deliveries that were planned much further out to be consolidated into that batch 2. And we're working with the Chinese suppliers to see how fast they can accelerate all of those supplies. And that will be an order of about 130 million. So over 4 times the size and scale of the order that we had on the first delivery. In that €130 million will be a supply line of gowns and overalls, about 11 million supplies, about 7.5 million gloves, 2.5 million face shields, 6 million respirator masks, 10 million surgical masks, 3 million gloves, a total value of 130 million. So additional supply lines have been opened also with other suppliers to give us resilience in terms of PPE. Just want to mention there is a significant issue emerging from China that the provinces, the regional provinces, have put in place stronger controls on the export of PPE, not to stop the exports, but to assess and assure the quality of the exports, to make sure that they are up to a quality and standards. That has a potential to threaten some of our supply line in terms of times, but we are at times for delivery. But we are working with our contacts through the IDA Ireland, the Irish ambassador in Beijing, Ambassador O'Malley, and indeed with the Chinese ambassador here in Dublin, Ambassador Hu, just to continue to make sure we accelerate that. So while we do have significant volumes coming through, I do want to state what I state each week. The supply of PPE will always remain a major challenge for us because the demands are very significant. And we 3 particular challenging lines of supply around gowns, respirator masks and long cuff nitrile gloves. And we are seeking other sources for some of those. So while we have secured, and we are in a much stronger position than many countries, particularly many countries in Europe and further, it still remains, it will continue to remain a key focus for us so that we keep our staff, and we keep healthcare workers, and we keep patients and the public safe. Therefore, we continue to urge all healthcare workers all across our locations and private locations to be extremely prudent in the use of PPE, ensure its use for the correct purposes, and that we can manage to a time that we get this longer sustainable supply. I'll very shortly address the issue of PPE supply for our long-term care facilities and particular nursing homes. Just to mention very briefly on ventilators, we have secured a very strong supply line of ventilators from 21 suppliers now, a total over 2,000 ventilators for delivery. So our sourcing exercise of ventilators has now completed, and we're now concentrating primarily on the delivery and distribution of these units. So I want to again thank our team who've managed, again in a very volatile market, to deliver that. I want to move briefly on now to nursing homes and just set out some of the actions that we are taking right now and some of the priority focus that we have both in long-term care settings, nursing homes, private and public. There are 354 long-term residential centres, facilities that have known confirmed suspect COVID cases. In terms of nursing homes, there's a total of 575 nursing homes overall registered with HIQA and on the overall older persons register. Of the 575 nursing homes, about 455 of those are private facilities. The remaining 120 are public facilities. As of the 18th of April, there's 248 known, confirmed or suspected outbreaks at such facilities, public and private. So about 60% where we don't have confirmed cases, 40% where we do have. Just briefly on the slide here, I won't go through all of the detail, but you can see a range of supports that we're putting in across all locations, all of our long-term care settings. And I'm happy to circulate this slide, particularly to media after. But you can see the range of supports that are being put in place, which range from PPE supplies, 247 locations where we'll be supporting it, public health support, 276 locations, infection prevention and control supports, 268 locations, and a wide range of telephone and other CHO supports provided in 261 locations. And you can see it broken down by nursing homes as well. So that kind of gives you a wider extent of some of the supports. But I do want to bring you through some specifics related to that. First point I just want to make is that in terms of providing some accommodation, I mentioned briefly that we want to provide and support accommodation for some staff in long-term care settings. Accommodation is being provided to almost 300 staff in those long-term care settings, facilities to support staff who may have been previously co-located with other staff, and we want to stop the transmission of the disease, or indeed other staff who are maybe living with somebody vulnerable at home, to provide them with some other locations close to their area of work. So 300 people have taken up that offer since it has been launched. Specifically, I want to just list off some of the particular supports that we are providing across all of the long-term care settings and indeed nursing homes and private nursing homes in particular. A range of financial supports that you'll be familiar has been launched by the Department and the Minister to support both in terms of COVID-19 expenses, maybe also in terms of agency staff recruitment. In terms of public health, we're providing a range of supports to support the identification of outbreaks and immediate advice from critical specialists to advise the locations of the appropriate actions to take. In terms of clinical supports, a wide range of supports which are in place, supporting sometimes from our acute hospitals with specialists like geriatricians or indeed other multidisciplinary supports from clinical professions into nursing homes in particular. Staffing supports, we provide staffing from a range of supports, whether it's be supplementing rosters or it's dedicated staff going in for a particular day for particular needs. It's staff to go in and advise, clinical staff and indeed nursing staff at various locations. HIQA and indeed the Mental Health Commission provide other particular supports around awareness, prevention control awareness, but also in relation to now preparedness plans of each centre and their preparedness, their readiness, if you like, particularly those centres that don't currently have cases of COVID-19. As you well know, we've prioritised testing in these locations for staff over the last while, and we've put in facilities to accelerate the testing for those areas. Some of this revolves around a prioritised, dedicated supply to our National Ambulance Service to go in directly, and I mentioned over the weekend we've done 4,000 tests. It also for GPs to accelerate a list through an electronic health system. And we are, as you recently know from the recent definition changes on Friday from NEFIT, Dr. Colm Henry will bring you through exactly how we're approaching that from our testing perspective. Some particular actions that we jointly agreed with NEFIT and ourselves that we're working through is around strengthened overall national and oversight and governance. And our Chief Clinical Officer, Dr. Colm Henry, is chairing a group around antimicrobial resistance and infection control, again to provide dedicated supports to various sites. Directors of nursing now in our CHO areas will take lead responsibility of interfacing with multidisciplinary teams going into the various locations. We've also put in supports now in terms of IT systems to give us better real-time information around cases and emerging outbreaks of cases so we can see it. That begins to be rolled out across all locations from April the 20th. It has been in place in a pilot location. In terms of transmission risks, we're putting in place dedicated quality teams in various locations immediately now, not just those who have cases, but those to avoid cases in the 60% where they don't currently exist. We're also putting in place general guidance which we continuously do around the movement of staff, and we've sent out directions through our National HR Director. We've also spoke with the agencies to supply staff to these care locations to ensure that we don't have staff working across multiple sites. And as I mentioned earlier on, over 300 staff have been provided with of these locations being provided with accommodation, again to support that mitigation. The staff screening and prioritisation I've mentioned, and I will give some detail just in terms of PPE, but obviously we're continuously focusing on the prioritised delivery of PPE to these locations and also oxygen. And finally, in terms of training and preparedness readiness, particularly lead role that HICWA will take in terms of preparedness readiness from a number of sites. Specifically related to PPE, I just want to briefly set out on the slide here the focus that we've been putting on the delivery of PPE over the last while, and particularly over the last weeks or so. And you will see early last week over 1 million items of PPE across 1,250 deliveries delivered with 1,000 deliveries of cartons, containers, pallets to various sites. It is a very challenging national infrastructure of these sites. Some of these sites are very small sites located all across Ireland, and we are taking an approach to get to all of those sites. On Friday alone, as you can see on the graph, 378 deliveries took place just on Friday to nursing homes, and 750,000 items of PPE on Friday alone. And what you can see from the chart just there across the range of supplies that we're delivering to nursing homes in particular, they have been prioritised because the blue element of the stack graph demonstrates the residential areas that are being delivered to. So you can see a high prioritisation being given to nursing homes on the distribution of PPE. So that's a kind of wide range of supports that we have in place, putting in place and have put in place, and the prioritisation that we're putting in terms of PPE. Finally, just wanted to reference very briefly on our recruitment continues and the Ireland On Call initiative. There are probably two elements to our recruitment currently going on. There is the Ireland On Call, and you'll have heard the figure of over 70,000 people did register the names. When you get down through that number, it starts to break itself down into a more meaningful number of people who can provide real supports in terms of dedicated frontline healthcare where we have the pressure. And it's about 27,000 numbers fit into that category. However, when you go through that number again, you're down to a number of about 12 to 13,000, which is about the numbers eliminates those who are already in healthcare settings, so providing healthcare workers, providing healthcare supports already in locations. So we don't want to be if you like, cannibalising from other locations. So that narrows the number down. We have recruited and offered contracts, in the process of offering contracts, to about 1,500 staff through that on-call process. 345, almost 350 nursing and midwives, about 280 doctors, about 280 healthcare assistants, and a range of other frontline supports that we can provide. So there's about 1,500 coming through that. But separately to that, I just want to say there's another 1,900 staff which are being recruited and have been recruited at various stages. They've either had contracts issued, they've either job offer accepted, or they're just working through a pipeline. It's about 1,900 separate to that process that would have been recruited directly into our healthcare and hospital settings. Again, some of those would have been on the on-call list as well, with some duplication. So overall, between two groups, about 3,500 recruitment over the last very short while. So that concludes my piece for this morning. I think I'm going to pass you on to Dr. Colm Henry for the next piece.
Thank you. I'll just be brief. The past couple of weeks, any of you who are attending those daily briefings will have heard from Professor Philip Nolan that his latest iteration of the modelling shows some signs of stabilisation of Covid-19 in our population, which is welcome. And of course, we're seeing this in our acute hospitals. While there are pressures there, we see signs of stabilisation in the number of new patients coming in, and in our intensive care units. We still have capacity in our intensive care units, and we're still scaling up in anticipation of any surge, but the numbers are stabilising over recent days to week. And our greatest challenge now is, of course, outbreaks in long-term residential care settings, and they present a number of significant challenges in terms of outbreak management, which is public health led and supported by our operations and supported by clinical staff both within and without the community setting. In the first instance, as we've seen in some of the cases during the week, the residents are in a particularly vulnerable setting. This virus is highly transmissible and carries a particularly high morbidity and mortality among older, frailer people. And secondly, the presentation in such people is sometimes unusual. It's not typical in terms of fever or cough or respiratory symptoms. We can present with somebody going off, not eating properly, or reduced mobility. And those who are already immobile or extremely frail, the signs may be so subtle as to be undetectable. When you compare the community setting with our hospital system, there's a much greater range in terms of their dispersal. We know there's 580 nursing home settings, 20% are public, the remaining private. The range isn't just geographical, it's in terms of size. Many are small, and the way they're run medically and nursing. And that care is provided by, in many cases, by GPs and nurses who've got to know the residents for many years, and are most familiar with their care needs, their medical background, and their own preferences, and indeed their family preferences, should they become ill. Now, as Paul mentioned, we're focusing now on ramping up our testing in long-term residential care facilities to focus on three groups. And the first group is that of healthcare workers and residents in any setting where there has been a suspected or known outbreak. The second is on all healthcare workers and all residents in any facility where there's a new case. And the third is healthcare workers in nursing home sector. And the reason we're doing that is so we can identify cases early, even in these groups which are asymptomatic. We can separate if appropriate based on public health advice. We can break the chain of transmission, and we can better understand the prevalence of the virus in what is a particularly vulnerable setting. And just to reiterate to finish, the care in these nursing homes, I know this from my own experience as a consultant geriatrician. I am based in the hospital, but in my own work I have connections with community hospitals. I know that care provided by general practitioners and nurses and the nursing home owners is often of a very high standard, usually of a very high standard. And the people who provide that care are most familiar with the patients, their needs, their medical background, their care preferences, and our aim is to support and enhance that care rather than replace it. Thank you.
Okay. Thanks, Paul and Colin both. So the way we'll run this is we have a microphone that David will bring to you. So if you just raise your hands, we'll try and keep this moving. We had at least 2 rounds of questions on last Friday, so if you don't get all of your questions in round 1, I'll come back to you, don't worry. What I will do is ask you, while I know who you are, people watching this at home won't know who you are or which media organisation you represent. So if you can introduce yourself, introduce your organisation, and put your hand up so I can see you, and I can see, Orla, that you got your hand up there already. So we'll start with you.
Just some facts on the nursing homes, first of all. You said that you'll have 4,000 tests done by the end of today, is that what you said? And how many in total do you have to do for staff and residents? And are you confident you can get that done in 7 to 10 days? And also, what is the PPE situation in nursing homes at the moment? Do nursing homes now have the PPE that they need?
Okay, we'll start with the PPE one, Paul.
Just on the PPE, as I set out on the presentation, we have prioritised, particularly last week, the vast bulk of our deliveries have been particularly going to nursing homes in particular. And so we have prioritised across a range of areas and supports. We're on a daily basis engaged with any areas that is under particular problems or demand. As I did mention, we are trying to be prudent in terms of proper use of it, but where there are particular locations, we want to know about them as quickly as possible, and our community organisations are dealing directly with them to address any immediate issues. But you'll see the supply lines being very significant.
Just want to bring David in just to follow on from that before we move on to the testing question.
So just in terms of the number of people in long-term care and taking the data from the nursing home support scheme, there are about 4,700 people in public or voluntary units and approximately 19,000 in private nursing homes. Now, there will be other beds that aren't part of the nursing home support scheme, but then you need to factor in there are approximately 9,000 people in residential care under a disability setting, and then there are additional numbers who would be in long-term care under a mental health heading as well. That'll give you some idea of the numbers, total numbers of people in long-term care, and then the staff who look after them.
Just get the microphone for your own camera, if nothing else.
What's the number for the staff in terms of the amount of people that have to be tested?
I don't have that in front of me, but and the staffing ratios vary from setting to setting. But if there are well over 30,000 people in long-term care, you'd be looking at least that sort of number in terms of staff as well.
Nursing homes is about 28,000, I understand, Orla. Okay, so that's PP bit. 4,000 tests. Do you want to take that one?
I think the question was how many in total. So the 4,000 tests have been done the weekend, 2,000 yesterday, and the remaining will be done today. Some were done Friday night. And that's a priority now for us now, as Dr. Henry outlined, the next scope and the numbers that David has just outlined to you, Orla. That's where we'll continue this. It will be a combination of tests done by the National Ambulance Service. Obviously, they will go into the care settings, but we are looking at other ways to test staff that may be more efficient. Could be bringing them to community centres or testing centres as well.
Okay, and capacity. You're happy enough with that in your question on capacity? Okay, Conal, did you want to come in? Again, introduce yourself, please.
Hi, Conal Thomas from the Journal.ie. It's just a question, I think, Colin, maybe, or Paul. The Minister said on Friday that doctors and nurses would be sent to nursing homes to help out. And I think about 61 HSE staff have been sent by that stage. Just wondering, can you give us an idea of how many have now been sent, how many you foresee being sent, and what exactly their roles will be?
Start with Colin and then I'll come to David.
Sorry, yeah, the number, first of all, the Minister did give that figure out, but it would be understating it to say that's the sole form of support. We know from across the country, for example, consultant geriatricians, Sean Kennelly in Tallaght, for example, has established video links with nursing homes. We know they're giving direct telephone advice. There are established links sometimes between medicine of the elderly departments and hospitals and long-term care settings. So there's a whole range of links that at one level are on-site support. And then there's consultation. We saw that in Portlaoise last week, where the staff from the acute hospital went to the facility to give direct advice and review each case. So the kind of clinical support and advice isn't just quantified in terms of numbers of people transferred to support, which obviously would be an important part of our work, but also in terms of that direct clinical support given by advice over the phone, by video link or by consultation. And that's something that was established long before COVID-19 and has been enhanced now.
Okay, so David, just come in on that, and then Siobhan, I'm going to ask you to add to that because it's an important question.
Yeah, and it's important to recognise too that this is more than just about the private nursing home sector. So we have to provide supports internally to our own units as well. So at this point in time, we've supported approximately 60 units with staffing. Some of those are internal units where we've lost significant numbers of staff through illness, and some of those are within the private nursing home side of things. And that's a figure that changes day on day as some units need very temporary support while they get organised to cope with the loss of staff, and others need more structured support over a period of time. So the figure as to how many staff are out there at any one time is difficult because it changes from shift to shift. So, but there are about 60 units right across the spectrum of care that have access support, and that support has come from within community services, with primary care staff being redeployed, from certain Section 38 agencies, and I'd especially mention the CRC, which has provided a lot of support, also from the acute hospitals, where staff have been redeployed in various parts of the country, Limerick, Drogheda, Dublin, Cork, but that changes from shift to shift and as circumstances change across the sector.
Okay, Siobhan?
Yeah, just I suppose to reinforce that the clinical expertise that's going in is really about improving the resilience of the sector in terms of being able to deal with outbreaks. They're very novel situations when they occur, obviously, within the facilities. The clinical presentations that Colm alluded to can be quite different. But I suppose reassuringly, we know that a lot of illness is actually being managed with very good supportive care in those facilities. And what geriatricians, palliative care physicians and others are able to offer GPs and directors of nursing and other colleagues are I suppose, the supports, the skill and the experience that they're learning throughout the sector and imparting that. Part of the fact of this is that it is a pandemic. We're in the early phases of it, and it is around, I suppose, that shared experience and learning being distributed as quickly as possible in terms of what's happening from one sector to the next.
Okay, so then Paul and then Danny.
Hi there, Paul O'Donoghue from the Times Ireland edition. You just mentioned that there were 248 confirmed or suspected cases of COVID in nursing homes. I think that was up from about 200 on Friday. Were there more cases confirmed over the weekend, and if so, how many? And then just was also mentioned as well that the COVID symptoms are often very difficult to detect in people in nursing homes. Is that why or part of the reason why at least there have been so many outbreaks in nursing homes?
Okay, let's deal with the numbers firstly.
So just to explain the numbers, and the figure the CEO gave covered the number of long-term care facilities that are being supported through the crisis management structures. So they would include outbreaks, suspected outbreaks, and where more active assistance is been given. So there may be some slight difference between what our colleagues in public health define as as outbreaks or suspected outbreaks. I think the figure given reflects the level of support been given. But that within that as well, or within the total figure, there are supports been given to 62 disability centres and 28 mental health facilities as well. So that's on top of the 248 older person services. So from a pure public health point of view, there's a very clear definition, and then but in terms of the actual level of support been given, that's reflected in the figures that the CEO gave earlier.
Okay, and then the difficulty of picking this up.
Good question. It's a new illness, a new pandemic, and you'd have known yourself from all the briefings going back weeks now that the case definition has changed because it's a new illness. The case definition as it pertains at the moment is that of fever and cough. But among older people, it's anybody who's anybody who's experienced in dealing with illness in older people, from nursing, allied health professional, medical, will know that illness is often unusual, particularly in frailer older people. And sometimes it's those signs you see, particularly in severe infection, you'd expect to see a high fever, and sometimes that fever is absent because their immune system is weaker and unable to marshal the same response other people might have, for example, in pneumonia. And that challenge becomes much more difficult as the person becomes frailer, because it's hard to detect subtle differences in their clinical state when they're already, for example, immobile or sometimes incommunicative and maybe not showing any signs of distress. So it does undoubtedly present particular difficulties in diagnosis and picking cases up. Hence the testing strategy to try and broaden out and look for all and test all residents and all healthcare workers in institutions where there have been outbreaks or suspected outbreaks, because we can't rely on the clinical symptoms or signs alone.
Siobhan, just want to bring you in there.
I suppose it's to reinforce again, I mean, it's important also to remember that these are healthcare settings where there are high levels of comorbid illness and also people becoming acutely unwell because of other secondary infections. So part of the art of this is actually around identifying COVID within that spectrum of illness that occurs anyway within these settings. We're very fortunate at having a very, I suppose, highly skilled workforce in terms of nursing and GP that do support nursing homes in our care setting, and I think that has allowed for us to be able to identify a lot of these outbreaks at an earlier stage than might otherwise be the case.
Do you want to come back in? I'll leave you come back in. Is it the same line of questioning?
That's a good question. You know, if you were listening to the Department of Health briefing on Friday, that there's one of the NEFA decisions on Friday was to do a survey of all nursing homes this weekend, where they're looking, asking them to report COVID and non-COVID deaths going back to January to see if there's any trends in mortality. And there are other people looking at this too. Our own HPSC are looking at trends in mortality to see if there's any unexpected rise beyond what one would expect. Hence the communication to funeral directors and others to expedite reporting so we can get real-time information. At this point in time, we haven't enough information to say that there's a rise in unexpected mortality in nursing homes. But as I say, that survey carried out this weekend will give us more information. And the HPSC reporting, especially with expedited reporting of mortality and death registration, will give us some sign as to whether or not there are some subtle cases that are going through under the radar in terms of people dying in residential care settings.
Okay, so Danny, then Aisling.
Good morning, Daniel McConnell from the Irish Examiner. Paul, if I could ask you just in relation to the PPE, you spoke about the volume that's now coming in. I suppose, given the issues with the first batch, are we fully assured that such issues won't happen again? And in terms of, I suppose, how can we quantify the loss to the taxpayer if there was any in relation to batch one? And again, I suppose, from an answer from the press office during the week said that there's no individual checks going on because the sheer volume that's coming in. What assurances can the public have that the quality of the stuff coming in is good enough? And second of all, just to further on from Paul's question in relation to the nursing homes, there's a deep concern in the community about that this has either been underreported, the quality of information not coming out, or that essentially the decision not to shut down nursing homes earlier on, I think Tony Holland made a decision not to shut them down, has expedited or caused a spike in the deaths. Can any of you address that point, please?
Okay. Can I firstly, Paul? Yeah.
Yeah, sorry, Danny, just briefly on the batch 1 delivery has been completed. As I mentioned in my presentation, any issues which emerged in batch 1, which were issues around respiratory masks, we immediately have taken it up at that stage with the supplier from China, who worked very proactively with us, I should say, in the last while, and I've assured that that order is addressed in our batch 2 delivery. On the quality checks that happened with them, and just to say that was if you can remember the presentation we did on our distribution centre, 80% of the orders from batch 1 were all fine and met quality standards. It was a 20% issue specifically related to masks. So again, that's to be addressed in batch 2. Specifically related to the quality and assessment of it, as we did for batch 1, every item is sent to our distribution centre in Clondalkin and indeed in Ballycullen in North Dublin. They are assessed by our infection control disease experts and teams, Professor Martin Cormican. We displayed all of these at the first delivery of it. That's where he does his full quality assurance check and test and assesses the quality of everything before it's distributed, and that will remain the case for batch 2.
I'd say that the difficulty with the response that you got, every single item isn't assessed. You can't assess, like, there's millions going out. So as Paul said, something like 30 million. Was it 30 million? You said 31 million items
in the first batch.
In the first batch. So you can't assess 31 million items, but categories are assessed for quality.
That would be normal QA process, the sampling process across each product line item.
Is there a financial cost, or is there financial, do we lose any money in terms of batch 1, or has that been kind of made up?
No, I think, as I mentioned on the first day in batch 1, we would use the particular masks for some use, but not for the use that we would have required, which is exactly what we addressed with the suppliers for batch 2.
Okay, so moving to the nursing home question then, the underreporting of that. So, Colm, you take that?
Owen, is it? Yeah. Sorry. With regard to nursing homes, in this country we are reporting on nursing home deaths. We want to report not just on known but suspected deaths, and as I mentioned earlier with the survey, we're trying to find out information beyond that again. And there are other countries, as you know, that haven't reported this. And to us, and other countries who are reporting, it's a really important facet of this illness to get a grip and to get an understanding and appreciation of how prevalent this virus is in a very vulnerable healthcare setting. And that survey I mentioned will give us richer information, and clearly the information coming back on death registrations the HPSC will review will tell us if there's any other trends that we haven't picked up on through direct known lab confirmed cases or even suspect cases. As regards the other question, all I can say is that this is from the beginning has been a fast-moving situation. We know so much more now than we knew even weeks ago. The case definition has changed, the focus has changed. It's not a few weeks ago that we were looking at acute hospital systems in other countries and seeing them overrun and their intensive care units overrun. And while we draw some solace from that and from our efforts at suppressing the virus in the community have been guardedly successful, clearly the biggest challenge for us now is nursing homes and the outbreaks there. And we're not unique this. This is a challenge faced by every country where Covid-19 has been, because of the vulnerability of that population and because of their susceptibility to the most extreme manifestation of this virus. It is undoubtedly a challenge. And it is becoming clear to us now that that we need to aggressively test these people, as I've outlined before, identify cases, go beyond the case definition and look at people who don't have symptoms at all, be they healthcare workers or residents, and test so we can extinguish outbreaks wherever they are.
So was there a mistake then not to show it?
I couldn't say it's a mistake, because what I can say is that decisions were made in real time in a fast-moving situation where there was limited information at that time. There's much more information now.
Paul, bring you in on that.
Danny, just want to make a few general, very brief points, just particularly around older persons and nursing home supports. And firstly, as Colm said, we are in Ireland following what is a worldwide trend, what's a European trend, in terms of the impact of this disease in particularly older persons, low congregated settings. That's what has happened, and we just want to reassure families and everybody concerned with residents in those settings. We in the HSE are doing everything we possibly can and will continue to work. This is a very new arrangement that we would be working with private nursing homes in the manner we're doing, and we're very pleased to do it, but it is a different way we would normally work. We're putting in a range of supports that I just said in my presentation around it, from staffing, from PPE to clinical supports, infection disease control, and we'll continue to do it. And just finally, just say I did pick up last night just a clip from NBC News in the US, where they were actually putting Ireland as a good example of how the health system has put our arms embraced around a private nursing home system. And I know it's very challenging, I know we have a lot more to do, and I want us to do a lot more. But I think there is a worldwide recognition. What we are doing is very significant and very comprehensive by many standards.
Okay, Aisling and then Ben.
Aisling Nicush, the Virgin Media News. Paul, can I ask you, you said that there was 350 nurses and midwives recruited. The INMO has told us that there's only been 6 that have been given contracts and are currently working in hospitals at the moment. So I'm just wondering, can you clarify that figure for me? And also, if I could just ask Dr. Henry, the mortality survey, will that be taking place in every nursing home across the country, or is it only in a number of nursing homes?
Okay, we'll start with you, Colin.
Surveying all nursing homes across the country for going back to January, asking about COVID-related and non-COVID-related deaths.
Okay, just on the
just
figures.
on the overall recruitment from the on-call, and I haven't heard the comments from the INMO, but we have made, what we have probably seen is we have to clear all of our candidates through the usual clearance process, etc. So there's 270 currently going through clearance. And there's 75, specifically of nursing and midwives, 270 currently going through clearance, which we guard a clearance process, etc. And 75 have completed clearance. That's the current numbers in terms of nursing and midwives. So in fairness to the IMO, I'd say they'd probably see a delay in them coming in. You wouldn't see those numbers just yet, but it is going through the clearance process. Well, 75 have completed their clearance and they will be signing up for it. The vast majority of them would either be working or are in the process of signing contracts. Now, separate to that again, and I can get some further figures, separate to that again, there is some direct recruitment going on in both our community organisations and our hospital organisations, which is the separate big 1,900 figure I gave you. But I'm happy to get a distribution of the figures that we have gone through clearance for you all. Okay,
that's you, Aisling, is it? Okay, Ben. And then Priscilla.
Ben Finnegan, News Talk. Of the 300 nursing home staff who've taken up the offer of accommodation, are they now all living on site in nursing homes, or is that based on location? Because a lot of nursing homes will be in rural areas. And Paul, you mentioned about staff being prudent with PPE until larger consignments come in. How long is this period of prudency going to be?
Okay, we'll start with you, David, on the staff and accommodation.
So the process we've put in place is that each community healthcare organisation through HSE Estates has access to a list of accommodation that's right across the country. So that's not on-site accommodation in on the grounds of a hospital or something like that. That is other types of accommodation that are available, but that will supplement other types of accommodation that many providers already have available to them. I mean, there are many private providers in particular who go through a process of recruiting healthcare staff from abroad, and as part of that provide them with accommodation. So what we're doing is supplementing that so that there are better options for healthcare staff who, for whatever reason, it would be more appropriate for them to have a separate accommodation. So that's that.
Okay with that, Ben, or do you need a follow-up on accommodation?
Is there more space for more than 300? Like, is there 1,000 beds?
Yes. Absolutely.
Yeah.
Okay. PPE then, Paul?
Yeah, and just to reassure, whatever other provisions we need to make for staff to reduce that mitigation of transmission or improve the mitigation, we will do that. Just on the PPE in particular, I've said this a number of times, PPE is now the new gold dust. It's gold dust. That's what it's like all around. There's a global, there's elements of kind of modern day piracy going on in terms of when we secure an order, somebody else is coming in to try outbid and get the order that we've secured. So it's going to be like this for a sustainable period of time. So when I say prudent, I would always ask people to be prudent in terms of the proper use of it. It is worldwide sought So we would always ask people to be prudent with it. But we want to get our supply lines better. We want to get a significant stock in hand for distribution. But we will always ask people to be prudent, particularly through a world pandemic that we're dealing with.
Okay, that's you, Ben. Priscilla.
Priscilla Lynch, Medical Independent. 3 questions, please. Firstly, of the 248 nursing homes that are currently impacted, how many exactly of those are private and how many are public? Secondly, are we looking more towards Ireland to get PPE supplies? I know there's one company that makes masks. Are we using other companies? And then thirdly, is there any information on the clinical assessment hubs? How many are up and running? And have we any data from how many people have been seen there?
Okay. First one. David.
And just in relation to the 248, I have that. I just haven't got it right here. I can give it to you straight afterwards, but I have that breakdown.
Okay. So,
sorry.
PPE.
Yeah, Priscilla, just on the masks, and I should have said it yet. We have had a good supply line for masks coming through from an Irish company, Arima, based in Limerick, and they have scaled up to double their capacity and probably treble their capacity very shortly. We are working to support another few Irish manufacturers who want to use the similar kind of template or specification and scale up there. So yeah, we have secured some from Irish manufacturers. We want to secure more from Irish, particularly in relation to masks.
You need to speak up. Very hard to hear you, Priscilla. Into the mic, please.
Some individuals are making scrubs and other items and say that they could make more, perhaps supplies if they could help the HSE.
Yeah, and again, our procurement teams are particularly working. We want to see our resilience built up in Ireland and Ireland manufacturers, and so they will continue to work with Irish-based companies who can supply us. Our preference is to get supplies from Ireland if it's possible, but it just hasn't been. If you look at the volume of what we are buying, it's in millions and millions. So we want to get resilience from Irish companies as well.
It's been pointed out in Europe that we're really going to have to source our own supply in future closer to home because of the strain on China, and obviously that we could be facing this for many months to come. So I suppose that's just why I'm asking that. Are we looking to try and build up more local supply chains as well? Yeah,
well, I think our strategy has always been from the start, firstly to secure a pipeline from world sources, and we were earlier to the market, just to say, than many other European countries. I know I'm stating this every week, but we are in a stronger position as tight as we are, and we are tight. But it was a dual strategy to get a supply line going and also work with Irish manufacturers to the extent that we can. It had to be both. I think you had a third question, if I... clinical assessment
David,
hubs.
on clinical assessment hubs update.
So, as you know, clinical assessment hubs are a really essential plank in the management of the disease over the coming months. And as of yesterday, 16 of those hubs have now opened around the country, 4 of those in Dublin City. So they're GP-led clinics that are by appointment only for people who have COVID-19 and are living at home or in the community. And they're staffed with, in addition to the GP leads, there are nurses, allied health professionals, paramedics, administrative staff and other support staff. So that number will increase day on day in order to meet demand. So I don't have an up-to-date figure on the number of referrals to date, but those hubs were just getting up and going on Thursday and Friday and yesterday. So I think the number of referrals Monday, Tuesday, Wednesday will give us a good indication of uptake then.
Okay, just Paul back in just for a second.
And sorry, Priscilla, I know David mentioned we can supply to you afterwards, but just roughly the breakdown of that 248 between public and private, it would be about 2/3 private, 1/3 public, but we'll get you the exact figures just after this.
Craig at the back there, David.
Hi, Craig Farr from the Irish Sun. There's some, just in relation to the testing that's being carried out in nursing homes. I've received reports from nursing homes in the Waterford and Kilkenny area that testing was carried out at some of their facilities yesterday, and that they were done so unannounced, meaning that only half or sometimes less than half of their workforce were actually on site to be tested. Do you think that these tests, that they should be carried out announced so that the entire workforce can be brought in and tested in one
Okay, Paul firstly, and then Colin. Yeah.
Just on it, look, firstly, we've mobilised significant crews over the weekend, and we wanted to make a start on this, that's to be straight. And we got into, obviously, there's an engagement when we get to a particular nursing home with the management of it, an engagement there and then. In terms of maximising the staff and that we can see, that's part of our operational planning now throughout next week. So how can we get the maximum number of staff to the right location for the greatest efficiency? And that may be, as I said, our clinical our community testing centres. So we wanted to make progress over the weekend. There's 4,000 being completed already, but the operational planning to get greater efficiencies continues through this week.
Okay, Colin, do you want to come in on that? Okay, I think that deals with it. Back to you, Colin. Oh, sorry, I get Ronan firstly because he hasn't been in.
Hi, Ronan McGreevy from the Irish Times. Question for Paul. Can HSE say if any private sector consultant has signed the proposed public-only contract? And if so, can the HSE give details? And the second question is about childcare arrangements for essential workers. Where are we with that?
Both of you, Paul.
Yeah. Just on the first one, you'll be aware there were continued discussions ongoing with the private consultants and a representative organisation. Went on right through to, I think it was Thursday of last week. A letter issued from ourselves, the HSE, to those individual consultants, then offering them now to sign up for the new contracts. Some have already signed up. I don't have the number, we can get it for you. But we expect, and I look straight away today, I'm urging everybody to sign on those contracts. This is a time where everybody is calling to all professions in Ireland, and everybody's making great commitments and great sacrifices. So I'm calling on all the consultants to sign those contracts, work with us through this very difficult phase, and I'm very confident that that's what will happen. Specifically in relation to childcare, it's still currently being discussed through both the NEFIT and senior officials in the relevant departments, and we await the outcome from that. From our perspective, it's still a factor that I'd like to see addressed. We did a survey amongst staff just over the last week or so. Approximately about 7,000 staff of our 140,000 or so either do have currently or foresee that they will have childcare issues. So we know as this happens over a longer period of time, people's arrangements might not be as sustainable. So while it's a smaller number, it's a number that we do want to do everything that we can to address. But it's still going through discussions at the moment.
Okay, that's you, Ronan. Okay, Conal. Just reintroduce yourself again. Just
Colin Thomas from the Journal.ie. One is in relation to the PPE batch 2. You mentioned, has that been assessed yet, quality assessed yet? And if that assessment isn't complete, when will it be?
Now, batch 2 started from the 18th of April, which is literally yesterday. So the first flights just start to arrive. That will be assessed as it comes. It's unpacked in our centre over. It's generally a 48-hour turnaround between it landing our dispatch centre, assessment of the clinical of the lines, and dispatch. So that will happen in the coming days.
Just have one more. I'm just wondering, could I get a comment in relation to a memo that was published in a nursing home in Dublin that described patients in a certain language? You know the memo I'm referring to, do you? And the language that was used therein?
Yeah.
I just want to pick it up and then I'll give it to David.
Yeah, I briefly pick it up. I haven't actually seen this memo right now to date, but it's not language that our experts and professional guys would use in terms of the assessment of the situation that's been there. So it's not language we'd support.
David, you have seen the memo.
I have, and I think the language is unacceptable in it, and it's really a matter of regret that any patient or their family would perceive from that they were being treated in any sort of differentiated way. But I'd also say that I really regret that once the memo was written and it went to the first person, that they didn't read it and say, I think you've got your language wrong here, you need to review it. So this needs to be a total team effort in addressing this disease, and staff need to support each other, and I would see that as a practical example of that. Well, if I wrote something like that, I would expect someone I gave it to say, no, you've got that wrong. You need to recast that in a sensible way. And I know it caused a lot of upset which is really unfortunate, and we just need to make sure that what we do issue reaches the highest standard possible and treats people with respect. So.
Okay, Colin, just come in on that.
Thank you for raising that up. Is that Professor Cormacan had nothing to do with that memo. He's anyone who knows him professionally and knows his contribution throughout this crisis will know what an outstanding professional he is and how much respect he has for patients, and how he always pursues his advice is given based on patient needs and as I said, born out of respect and for patients and their welfare. So. Not in relation to patients. No. I would be uncomfortable with that language in referencing even a place. I think it is no place in medical terminology or in the advice we give. However technical it may be parsed, it is no place.
Okay, back to Orla. En ceist as Gaeilge, Orla? In Kesh Askelga.
Yeah, I've just two questions. One is in relation to, there's a respiratory doctor from St James's Hospital on Twitter this morning appealing for gowns from the public. Is that a concern to you that somebody of that level in an acute hospital is having to make that appeal at this stage? Secondly, just the 4,000 tests completed, is that completed and results given, or just that the tests will have been taken? That's just to clarify that. And thirdly, just if Dr Henry could address the issue of testing in nursing homes and what's going on.
Okay, so we'll start with we're not aware of the St James's one, by the way, so do you want to pick
that
up?
I'm not specifically aware of that one, but we are working with all of our, particularly all of our hospitals, acute whether Section 38s or whatever hospitals we're working with. And we've had a very good accelerated delivery process where particularly areas have got into butter in terms of supply. So we've been redistributing even between hospitals and redistributing from our own dispatch centre as well. There has been, as you've probably seen over the last few weeks, there has been some donations delivered from various very well-intended members of the public and from enterprises. And some of that has been delivered directly to our either hospitals or social care areas. But we have put stronger controls now for that to go back through our distribution centre and to be assessed from a quality standard. And I want to thank some of those donors in particular over the last few weeks. Just on the 4,000 tests that were done.
Before we move off that one, Colin, just on the gowns. And I think we'd all accept that gowns are particularly difficult to get, Orla. So we're not.
We were particularly challenging gowns this last weekend. Since then, there's been, and indeed I had to communicate with hospitals to tell them that we're running low in stock centrally, although some hospitals had their own stock that they were eating into. But since then, as Paul alluded to, there's been a number of shipments which have significantly enhanced our stock of gowns. But given the ongoing demand, and which is unprecedented, not just in hospitals but in the community, our language and our advice to our staff is the same. We want to protect them. We want to protect patients. We want to avoid transmission. We want those gowns and all elements of PPE to be used in the appropriate clinical settings, wherever that may be. And that's where that term prudence comes in, is that we don't want them misused in inappropriate clinical settings, because that means somebody else who needs the gown or needs the gloves, needs the goggle, may not have access. But at this point in time, our gowns have been supplemented by additional shipments coming through this past week, and we are in a better position now than we were last weekend.
Okay, so
just specifically just on that, if I can say, the batch 2 orders that we're trying to accelerate for the batches ahead does have a total of about 11 million gowns that we're trying to secure. But again, they'll be over a long number of flights over a few weeks. So again, as Dr Henry said, that's exactly what we're trying to make sure have proper use. But if we get 11 million gowns, we will be in a stronger position, obviously. On the 4,000 swab tests completed the weekend, so it was actually the swab tests. We've tried to aim to put in an accelerated process for those now to go directly to various labs. Some will be based on location, or some will be based on the quickest turnaround we can do. So they've been sent, or in the process of being sent, to the various labs for testing and results now.
Okay, then ask Helga. Craig.
So Madrid sin choras tá stálar dús begin dúine choras úra chuir le chéile siad cúpla seachtain ó is an duine agus hoisimuid le honad tá stála a chuir le chéile chuir bhon agus tá muid dridiminis lechéadacha inis tá siad ag feimú inis agus cumáile sin ní muid ag brathní is mó ar an sír an bháin tá fi cheannas má chogúlaí a hallann sin ag chuúlann seomar cílín de gascan so tá muid ag dridiminis de trocha síran sa bhreis agus idir na síran sin agus an tastála tá muid ag dul an nec leis an scóine a bhí ann agus tá sin an aib sin réite agin inis. Nis an rud is tátaí dúine ná áhach go ddíireach agus an scéim sin a díú ar an títhe altanis. Sin an áit ina bhfuil an deachtaí mó tá aginine agus tá mar dúirs mé ceanna méle tá muid ag díú an scéimenis ar a duine san títhe altanis ina bhfuil ráganna ar bhon ceanna féin, bhfuil ráganna agus tá is agad maidir leis na hifircha sin agus tá muid ag díú an scéim sin fosta ar na heblia ilig sa náráil sláinte. Is cum a cahat bhfuil siad, is cum ceacha an bhfuil rágán na nach bhfuil rágán sa dóis gona muid ábalta a duine aimsú chu gastas féidir.
Okay, gur maith agat, Dr. Henry. Danny, Asperla nó Askelga? Asperla, gur maith.
Danny McConnell again from the Irish Examiner. Paul, just to pick up on your comments earlier on about PPE being like gold dust, and I think you used the phrase piracy. Can we get into some more detail as to how you are, I suppose, combating that, and are we especially having to pay over the odds to kind of get the supply that we're getting?
I'll just say two things on it. Firstly, since the start of this pandemic, the availability has been our primary challenge. Finding secure lines. When I mentioned the word privacy, what I actually mean is what's happening is whether it's for PPE, whether it's for ventilators, whether it's for reagents, as soon as you think you have a stock secured, somebody somewhere in the world is outbidding you, whether that's at the delivery stage or it's nearly at the export stage. So there's a lot of piracy, modern day piracy I described as going on. From our perspective, we paid what we believe was a reasonable price at the right point in time. Our priority was obviously the protection of our staff and the protection of our patients, protection of our public overall, and that's been a priority and will continue to be so. So there's no doubt there are certainly premium prices being paid on the market. We did get in earlier and secure a very significant order of 210 million or so.
Okay, Sasta. Ronan.
The Irish Times, just to follow up to that, Paul. You talked about piracy. There are anecdotal cases of Americans coming in and taking PPE that was bound for Germany. At any stage, was any PPE equipment that was bound for Ireland taken by anybody else?
No, we've secured all of our line that was supplied by us. It doesn't mean it didn't come under some pressure, but whether it's ventilators or PPE or indeed reagents of late, we've secured what was being committed to us. And I want to specifically thank the ambassador of China here in Ireland, Ambassador Hu, has worked very proactively with us, and our IDA and Department of Foreign Affairs and Trade. If we didn't have that War Guide support, that many countries don't, we wouldn't have secured what we have secured, and I want to thank them for that. And indeed the company China Pharmaceuticals, who have worked very, very well with us over the last while.
Finish, Ronan, yeah? Okay, back to Aisling.
Paul, can I just ask you, of the 3,500 medical staff recruited in the call, how quickly do you see these people actually getting in and working on the front line for us? Is there a delay in getting them into the hospitals and into the positions they should be in? Or why aren't they being, if they're recruited, why aren't they being cleared a bit quicker and into our hospitals a bit quicker?
Yeah. So just on it, across all the range, just to clarify again, 1,500 have come directly from the on-call, and about 1,900 have come from a parallel process that has been going on for weeks as well. And there is, first of all, when you work through this process, the interviewing stage is the contacting of people. The agreement for people to sign up after they put their name forward does take a significant period of time. The Garda clearance and the Garda have worked with us very well and very strong to accelerate clearance process for us. You offer some contracts, you offer employment, and some people don't take it up. You know, they were at the time available, they're no longer now. So you have a whole set of processes that are going on that it doesn't accelerate very quickly. But there are very significant numbers that we have secured, we have offered contracts to, and significant numbers have come in. Happy to provide them with you, to you as well, Aisling.
It's important to say as well, Aisling, that the individuals have to take the offer as well. So, it's up to the individuals to actually take the offer, and we have to go through that process as well.
Who have been offered positions who have then declined the positions?
There's some of that evident, yeah.
There's a lot of people who would have offered from various professions, whether it's nursing, healthcare workers, doctors, who put the name forward, and as you get through the process, they're no longer available or decided not to now at this stage. So you start with a very high number, and it does end up with a much smaller number, and that's understandable. We knew that's what we were going to face into.
Okay, back over. Here we go, Priscilla.
Priscilla Lynchkin. Some doctors
just
have
speak up a little
me.
bit, Priscilla. You're a little faint.
Some doctors have contacted me saying they're very concerned about community care workers going into homes where there's elderly, vulnerable people, and that they could be the next population at risk, particularly as they don't seem to be getting very much PPE. Could we have an update on that? Secondly, are we looking at official efforts to re-sterilise some PPE? I know that can be difficult, but I know UV sterilisation can work in some circumstances. And finally, Tony Holohan said that we should resume activity as soon as we can where there is capacity, i.e. the private hospitals are lying idle essentially, and we're paying a lot of money to rent them. So is there plans to try and start activity there as soon as possible?
Okay, Colin, we'll start with you on the community. Could you hear it? Because I was finding it really hard to hear you. David is going to take it, okay.
So in relation to healthcare workers visiting people in their homes, so we follow the clinical guidance in relation to what the appropriate level of PPE is, and as that clinical guidance is modified, then we will modify practice. But currently, if a healthcare worker is going into a home where there's a suspected or known COVID case, then the exact same PPE requirements apply as in any other clinical setting.
Saying that they don't have the PPE, so they're just asking for PPE, really, I suppose, is the problem.
Well, the guidance is very clear that they shouldn't go in unless they have that PPE. So if those issues are been flagged up the system in the appropriate way, they should be dealt with in the exact same way as any other PPE requirement across the system.
Okay, your second question, sorry Priscilla, just repeat it, will you please?
I know some countries are looking at re-sterilising PPE that's been used in low-risk situations. I know we can do it with goggles, but there's been work done on UV sterilisation as well of gowns and other items. Is that something we're looking at officially in Ireland?
Before we secured the Chinese shipment through Ambassador Hu, we had to look at that for goggles because we ran out of goggles in the country, but there are other elements that don't lend themselves well to that. So I'm afraid masks, gowns certainly, so they don't. So goggles lend themselves more readily to that. But the advice we gave when our stocks were much lower focused on exactly that and how we would, as to use that word again, use the existing stock most prudently. And when we ran out of goggles, we certainly were advising people how to clean them and sterilise them for reuse. But fortunately, we're not in that situation despite ongoing unprecedented pressures.
Okay, the last one, Paul, to you about getting back to some form of business as usual.
Yes, sorry, Priscilla, I think your question was particularly related to other treatments and being used of the hospital. Yeah, and we, at every briefing, particularly over the last couple of weeks, we're strongly urging the public to where they need particular treatment, that they should come forward for it. And because some treatment is time dependent, you may have treatment of chemotherapy, radiology, cardiovascular, time dependent surgery, that's there, endoscopy, and we would be strongly advising the public come forward for the treatment through your normal referral. But the hospitals are there to treat people who need particular treatment, and we would have a concern that people may have not come forward, and we'd urge them to make sure they do get their required treatment. That's across the public and indeed the private system that we now have available to us.
Okay, Paul, back over to you. I'm going to wrap this up soon now, guys, because we've been an hour and 20 minutes here.
Paul O'Donoghue from the Times Ireland again. There's a report today in the Sunday Independent that Minister Harris is considering reopening schools for 1 day a week, kind of before the end of the summer. Is that something that the HSE has looked at? And if so, how would that work with social distancing?
No, I mean, I say this at every briefing every week. From a HSE perspective, we'll take whatever guidance comes from government. That's sourced generally through an effort to government, and we're the ones who implement whatever the decisions are. So it's not something that we've directly put forward recommendations on from a HSE perspective.
Okay. Are there any last questions from anybody? Okay, listen, thank you all for coming here today. I hope you found it useful and interesting, and we will have another one of these at some stage next week. Thank you very much.
Hello and welcome. Now, even though it's been a cloudy start to our Sunday,